and welcome to the weekly PHO online teaching sessions. As usual, we have a very esteemed panel today discussing a very important and a common topic in our day-to-day practice. So we'll be discussing low risk and intermediate risk neuroblastomas today. And thank you, Manas, for again, volunteering to moderate the session for today. And also, as usual, getting together, multidisciplinary stalwarts in the field to discuss the various aspects of care in neuroblastoma. So I'll take the privilege of introducing the experts for today. So we have Manas, Dr. Manas Kalra, who is the consultant of pediatric hematology oncology at Sir Gangaram Hospital, who is being the moderator for today's session. We have Dr. Praveen Kumar, who is a consultant pediatric neurologist at Sir Gangaram Hospital as well. So welcome, Dr. Praveen, and thank you for your time. Dr. Sandeep Agarwala, who doesn't require introduction to this audience. We have heard Sir at various forums and for so many years now. He's head of pediatric surgery at All India Institute of Medical Sciences, Delhi. We have Dr. Vikramjit Kanwar, again, non-introduction. He's director at the Cure Hematology Oncology and Stem Cell Transplant Center, Ahmedabad. Welcome, Dr. Vikramjit. Professor Mukta Ramadwar, who is not joined yet, but she, as we know, she's a very senior oncopathologist at TMH Mumbai. And we also have Dr. Samarjit Singh, who is a senior consultant in Department of Radio Diagnosis at Sir Gangaram Hospital in New Delhi. And we'll have fellows from Sir Gangaram Hospital going to present the cases. And the format is the same. So we'll have a couple of didactic lectures before the case presentations, one on the paraneoplastic manifestations of neuroblastoma. And there will be having some case discussions on low risk and intermediate risk neuroblastoma. So thank you very much, all of you, for your time, and all the students and the faculty have logged in. As I requested last time, this has been a requirement of ECHO to keep the videos on. So I request, especially the students, please keep your videos on and interact in the chat box. And you can also raise your hand to ask a question. So over to you, Manas, for the next 1.5 hours. Thank you very much.
Thank you, Sunil, for giving me this opportunity. Thank you, PHO chapter and the organizing team for this PHO academic program. It's been a really interesting 4-5 month journey, I must say, of all these teachings. And I think it has been wonderful. The feedback has been great. So we are going to do a attempt to talk about low risk, intermediate risk neuroblastoma and this, specialized a very unusual kind of a syndrome that is associated with it, that is Opsoclonus Myoclonus. So I would like to thank all the experts and we would begin the session with the Opsoclonus Myoclonus. So we as oncologists are involved once a diagnosis is made, once we have found that there is a neuroblastoma, or if there is a suspicion of a neuroblastoma and we are trying to do the witch hunt and trying to find where it is. But the stage is initially, the beginning of this whole treatment or the diagnosis comes from the perspective of a neurologist, because most of the times this patient comes to a pediatrician and then is seen by a neurologist, and then we get involved. So I thought it would be really appropriate to have our pediatric neurologist, Dr. Praveen Kumar, to talk about Opsoclonus Myoclonus Ataxia Syndrome and explain to us how clinically these children present. And then I'll be talking about the oncological aspects of this syndrome. So over to you, Dr. Praveen.
Thanks a lot. Thanks a lot, Dr. Manas. So I'll start sharing my slides. So can you all see the slides?
Yes, we can, Dr. Praveen.
Yeah.
Go ahead.
So a very good afternoon to all of you. And at the outset, I would like to thank the PHO chapter and our hemat-oncology team, Dr. Manas, Dr. Anupam, for including me in this scientific session. So as Dr. Manas also told that maybe I'll be discussing about, in brief, about the basic neurology involved in cases of Opsoclonus, Myoclonus, Ataxia syndrome. Let us say this case. This child came to me a couple of years back. This was a young child from Assam and he had a history of recurrent vomiting for past almost 3 weeks, and then he had a history of unable to sit up for past 2 weeks, and the parents and the caregivers thought that he is not sitting up because he is having recurrent episodes of vomiting for past 2 or 3 weeks in that part. He had unremarkable birth, developmental, and family history. So let us look at the way he is setting up. Definitely you can make out that he required some support to sit up, age of 16 months of the age, and before this he was basically walking in the way. So he has got unsteady part, he can't sit up well in the part. So before coming to us, he was already evaluated thoroughly outside after admission for the vomiting and this part. His MRI brain, his EEG, the CSF analysis, metabolic screen, including the NCV, EMG, all were found to be normal. But because he was still having, some vomiting had reduced basically, but now because he was more a kind of like unsteady, he was not sitting up, that's why they brought him to us. So look at the way when we examine him in this subsequent admission, so definitely you can make out that he has got some ataxia of the upper limbs also. The way he is holding the biscuits with his hand is not appropriate for a 16-month-old child. So this is very important for us to see clinically that children at this age are naturally also a bit unsteady. So they are a bit clumsy basically. So it's not easy to identify unsteadiness or ataxia at this age group. So it will be the real challenge basically, especially in the younger age group basically. So you have to go back and look at their basic part, how the movements were there, how smooth were there before the whole thing began. So definitely he has got some amount of appendicular ataxia. His movements in the upper limbs are not smooth basically. And when we looked at him, definitely we could find out that he had got Opsoclonus also. We'll talk about this in some other slide basically. And on the history, parents noted that and reported that he had jerks in their lab basically. So these things are important because a lot of these kids clinically, when they come to us basically with the gait difficulty. A lot of them basically come with the gait difficulty. Sometimes they come with the myoclonic part basically, but Opsoclonus is very, very hard to be diagnosed by the, by the caregivers basically, and even by the general physicians on that aspect. So for that aspect, for the myoclonus and Opsoclonus, we need to go back and ask in the history, or we have to, relive it basically to diagnose this is basically an ataxia, which is associated with the Opsoclonus also and with the myoclonus also in this case. So like he had ataxia, and when we found that he has got Opsoclonus also, when looking at the eyes basically, and there was a history of myoclonus from the parents, it was, confirmed as the case of Opsoclonus myoclonus ataxia syndrome. We went further, we got his MRI brain, MRI spine, and thereafter the PET CT done, and it is showing basically the right superior mass over here, this location, over this part basically, and this part, which was batten up with the PET scan in the FDG uptake, and subsequently he was operated, and you can see the mass over here. We put him on the ACTH by the time he was going for the operation part, and definitely it reduced his symptoms in form of the ataxia part, the myoclonus part, and in the terms of his the Opsoclonus part also. And he is still with us, almost now is close to a couple of years, and he has been doing fantastic in these intervening years. So Opsoclonus myoclonus ataxia syndrome, we know that it requires 3 of the 4 clinical characteristics, including the myoclonus or ataxia, which we have to identify basically, Opsoclonus, behavioral abnormality, which is quite important from the pediatrics point of view, and definitely we have to look for any associated neuroblastoma in such kinds of cases. So look at these symptoms one by one. A number of times you'll find that these symptoms or these features are not there in one go. We had a series of cases, one of the cases which we had where we got the child with the ataxia, and subsequently he had this Opsoclonus myoclonus part in the part without having any neuroblastoma. And other case which we published basically where he came first to the pediatric surgery and he had some urinary issues. They diagnosed to have posterior valve, and subsequently he was found to have ataxia and then referred to us, and we found that he had got ataxia followed by Opsoclonus part also. So the message is this, that these all features of Opsoclonus, Myoclonus, Ataxia syndrome may not be apparent at the first go in your first visit. You most of the time they will come to you with the ataxia, as we mentioned, or maybe subtle gait difficulty. You have to identify the ataxia part, and then you have to look for the other signs which may be suggestive of Opsoclonus, Myoclonus, Ataxia syndrome in those cases. Mostly they present in around 2 to 3 years of the age group, and that's why it becomes quite challenging to identify the ataxia in these cases, because this is a normal developmental age where you find children are a bit wobbly, so they are not walking very smooth at this age basically. And that is why, as I mentioned to you in the beginning, that we have to go back to their baseline level, how the child was doing before the whole illness started, to identify that the child is unsteady, he is wobbly, and he is having basically ataxia in the part. Sometimes you can have some preceding viral illnesses basically in the part. And as we mentioned that all the symptoms may not be present in the beginning, they may start with the ataxia or the gait difficulty. So look at this child. This will be easy to understand the way he is standing up basically. So definitely a child who is alert, awake, he's not irritable, and he can't stand of his own basically. This is ataxia of his stance basically. So unsteadiness in these cases. This was a child with the other diagnosis for the ataxia, acute or post-infectious cerebral ataxia, but this just illustrates that you have to identify ataxia in these cases. And ataxia, to make it more simple, you have to understand that this is just a clumsiness. So in pediatric, especially in the younger children, they won't be able to do you the heel, knee, or the finger nose test. Their movements are uncoordinated, the movements are not smooth, and they require basically some support, maybe sometimes to stand up and do the work in that form. It's a common problem, and the etiology is huge for the ataxia part. In those cases, it's basically a symptom, and you have to identify basically the underlying causes in these cases. A brief about the part. Mostly you find that the movements are governed by the cerebellum. You get the command from the cortex, and you find that the command copy is going to the cerebellum also. Cerebellum also receives the afferents from the joints, the muscle spindles, and it matches what the command has been given from the cerebral cortex, from the motor cortex, and what the muscles and joints are doing. So if there is some amount of mismatch, cerebellum tries to insert the corrections. So that is basically the function of the cerebellum. So it means that if you have got any, motor cortex problem, if you have got any spinal cord problem, if you have got any afferent problems from the muscles and spindles, or if you have got any cerebellar problems, they all can give rise to the ataxia. And that is why ataxia has got a whole lot of neuroanatomical basis. You look at the cerebellum, you look at the cortex, you look at the sensory pathway basically before you diagnose. This is a kind of like cerebellar issues and not a non-cerebral issues to diagnose at this conclusion. Depending upon the, the way it has presented, it has various causes. Sometimes it can be because of congenital malformations, it can be because of drugs, it can be post-infectious, which is very common in pediatric age group, acute post-infectious cerebellar ataxia in those cases. And at the same time, you find ataxia because of the Opsoclonus, Myoclonus, Ataxia syndrome, which are basically chronic and which are basically mostly progressive in nature in the part. But there are multiple causes, and we need to look at from the anatomical part, from the age of onset, and how the things are progressing in the part. The second component of OMS is the myoclonus part. Look at this child. He came to me yesterday. Just is a kind of like the way he's standing, and then suddenly he starts having, yeah. So this is typical of myoclonus, a sudden, brief, shock-like involuntary movements. And many of times you will find that in cases of OMS, they are difficult to, visualize. You have to ask from the parents whether this child is having any shock-like movements in their lap or not, to make sure that this is a myoclonic movement. Basically, myoclonus can be physiological, as we see sleep myoclonus in the young kids. It can be epileptic, this child, what we just saw the video was having basically. It can be symptomatic, like in cases of HIE and those cases, or it can be idiopathic also, or hereditary also in those cases. It can be affecting any parts of the body basically, the limbs, the trunks, and anything basically. And you find that myoclonus may be present in the sleep also. That's why sometimes they can give an history that the child is basically having some kind of jerks. And this can also prevent the child from standing or the sitting. So you also have to differentiate that the child is not standing. Is it because of the ataxia part, or the myoclonus is also a component of this problem? The third is the Opsoclonus, and this is one of the most, I will feel that clinically most distinguishing of the Opsoclonus, Myoclonus, Ataxia syndrome, basically, because ataxia is common, Myoclonus is common, but Opsoclonus is not clinically, neurologically common. So we don't see Opsoclonus so often without having Opsoclonus, Myoclonus, Ataxia syndrome, basically. And the movements in the Opsoclonus is basically an ocular dyskinesia. So ocular movements are not normal. They are rapid movements. They are multivariate in multiple directions of the eyes, basically. They are involuntary movements, quite chaotic, and in both the eyes together. This is like conjugate movement, basically, Opsoclonus movements. And they happen in the sleep also, with the eyes closed also. Even when the child is sleeping, you can ask the parents that, do you find any movements inside the eyelids? They may tell you that their eyes are basically in the rapidly jerking movement if you can't see it. Look at this child. This is other case, basically. And focus at his eyes. You'll find basically at this part. Multi-directional movement, which is quite chaotic, high amplitude, basically. And it's very difficult to miss if you can see it in that part. Sometimes what you can do clinically is that you can show something from the distance, and you bring the thing closer to their eyes, and you'll find that they start showing the Opsoclonus part in the way. And this is a bit different from the Nystagmus. Look at this child with the Nystagmus. Nystagmus is basically in horizontal eye movements, or maybe up bit or down bit, but they have got a fast and the slow component, while Opsoclonus doesn't have any slow component. Opsoclonus only has the fast component, the saccadic movement, basically, in all the directions. This was a child with Joubert syndrome, again a cerebral problem, basically. While ocular flutter is also a kind of thing which is confused with the Opsoclonus, basically. Ocular flutter is also is only in one direction, horizontal direction, and it doesn't have any slow phase. So horizontal fast movements is basically ocular flutter. Sometimes they have described ocular flutter also in cases of either evolving Opsoclonus or resolving Opsomyoclonus, basically. So it means it can be a preceding or maybe the relieving factor of the Opsoclonus also. And most of them, they have got the similar kind of pathophysiology, basically, so far as the mechanism is concerned, in a way. And last in the list of this Opsoclonus Myoclonus syndrome is the behavioral changes. And this is very important because most of the DDs which you'll find with the acute ataxia may not have the behavioral changes, like acute post-infectious cerebral ataxia, which is more common with the pediatric age group, basically. So there you find a child who is active, alert, and ataxic post-URTI, kind of any viral illness. While OMS can also happen post-URTI, but here you find a child who is ataxic and is very, very irritable. He has got some sleep issues. He has got some behavioral issues, basically, the mood disorders, basically, in those cases. And sometimes it becomes a main clinching diagnostic feature. A child who has been ataxic because of drug intake is basically more drowsy, while a child who is ataxic with the Opsoclonus Myoclonus syndrome is basically more irritable, more agitated in that sort. There's no one pathology why they have got behavioral issues. Sometimes they say this may be because of oscillopsia, when the eye movements are taking place in such a fast and rapid direction that it also makes them scared because they can't see clearly the outer world. Even the cerebellum is also involved in the cognitive functions. It can be because of the cerebral cognitive dysfunction also, because there have been cases reported with the OMS having severe kind of encephalopathy part also, basically. But this is one of the important things to be remembered whenever we see a child with ataxia, because I think this is the part from the Opsoclonus. The behavioral problem is other thing which points you towards the OMSs as compared to any other differences in those parts. So to conclude, this is definitely a neurological entity which is not very, very common. This is uncommon, this is rare, but we have to keep this possibility whenever we see a child who has come with the ataxia, and look for the Opsoclonus, ask for the Myoclonus part, basically, and you may clinches the diagnosis. Sometimes you may find that the Opsoclonus may take months. They have described almost around 1.5 years after ataxia when the Opsoclonus has come, basically. So whenever we discharge a child with ataxia, we let them know that this diagnosis is not complete. You have to monitor him. If at all you find any kind of abnormal eye movements, you have to come back to us, basically. So child with ataxia, if it has not been found any identified cause, it is still under evaluation, especially in around the 2 to 3 years of the age group. So they must be evaluated periodically in that part. And once we have clinically diagnosed, then we go for the lab investigations to look for any parainfectious or post-infectious causes basically, and they require a multidisciplinary management, which I think Dr. Manas will discuss in detail about these cases. So thank you very much. Thanks a lot.
Thank you, Praveen. I'll now be talking about Opsoclonus myoclonus in the setting of neuroblastoma. So I hope my slides are visible.
Yeah.
Thank you, Praveen, for giving that overview. So Opsoclonus myoclonus is also known as Kinsbone syndrome, dancing eye, dancing feet syndrome, or infantile polymyotonia. It is a rare and a primary immune-mediated disease, and the incidence is somewhere around 0.18 cases per million population per year. It is associated with both paraneoplastic and parainfectious states. This disease, if you look at Opsoclonus myoclonus per se, almost 50% will have a neuroblastoma. But if you look at neuroblastoma per se, then only 1 to 2% will come with OMS. The causes are mainly cancers, which you can see that in this slide. In pediatric age group, it is mainly neuroblastoma. There can be rare thyroid cancers, but in adults, it is mainly small cell carcinoma of the lung, breast cancers, or thyroid malignancies, which can present with Opsoclonus myoclonus syndrome. When there is no tumor, it is most of the times it is associated with infections like HIV, EBV, and all the other rare viruses, and sometimes bacteria like Streptococcus, Mycoplasma pneumonia, and then some rare illnesses like celiac disease, cocaine abuse, post-allogenic stem cell transplant, and these are all, anecdotally reported or just in the forms of case reports. These patients have been reported. The pathogenesis of this disease mainly is an autoimmune process, and how that was found was because when they treated with immunomodulation, these patients started getting better, and that is when they tried to look into more and more of why this was happening and found some autoantibodies to childhood OMS. The most common ones are the anti-Purkinje cell cytoplasm antibodies and sometimes anti-HU antibodies, mainly seen in adults. Then when they worked on the CSF cytokines and all the other pathways, the T cell and the B cell pathway, they found a host of immune-mediated abnormalities going on in these patients, which were probably responsible for this kind of an autoimmune phenomena, like a B cell expansion in many cases. And that is what the basis of using drugs like rituximab has been. And in the T cells and the tumor immunological aspects, they found that these patients had lower number of CD4 T lymphocytes in the CSF and lower number of CD8 ratio in blood with the increase in B cells. So all this leads to an autoimmune process, and this autoimmune process manifests itself in the form of a OM. And this leads to an OMAS-like picture. So this is one cartoon just showing the similar kind of a situation. So either it's the neuroblastoma or the virus which is responsible. They've got the antigens present in them, and they go to the antigen presenting cell. This triggers the B cell and the rest T cell, which leads to an activated B cell formation or an activated T cell formation. And then with the TH-TS pathways and the help of cytokines, antibodies are produced, which lead to brain injury. And this leads to the clinical manifestation of OMAS. Coming to the so the neuroblastomas associated with OMAS usually have a better prognosis. They are more differentiated. They have limited stage presentation, and the overall outcome of these patients from the neuroblastoma aspect is very good. However, what limits their outcome in life is actually OMAS per se. The OMAS leaves the child with a lot of sequelae, like that of mental retardation, may leave the child with severe learning disabilities. And although some neurological symptoms improve, still a lot of patients are left with a lot of sequelae, which limits the overall outcome in their quality of life. Now, OMS in a tumor setting or a non-tumor setting. So this was the largest study with 356 children in the US who had OMS, and they could not really find that from the neurologic, oncologic, epidemiologic, neuroimmunologic or neuropharmacological aspects, any difference between tumor versus no tumor group. So what they said was that this is basically one disease, but the reasons may be two different reasons. And the treatment basis will, immunomodulatory treatment basis will not differ in both the situations. Now coming to screening protocol, so every child who has OMAS should be screened for an underlying neuroblastoma. We would recommend doing an ultrasound or a chest x-ray initially, but often the tumor is not picked by this because it can be a very small tumor sitting somewhere quietly. And in those situations, an MIBG scan or a PET scan may be helpful, and a urinary catecholamine estimation may give us a hint if there is a neuroblastoma sitting somewhere. Whole body MRI as a routine screening is better as compared to CT scan, because if you are doing 3 to 4 monthly evaluation of these patients with ataxia and opsoclonus, you'll be exposing them with too much of radiation if you keep doing regular CT scans in these patients. However, failure to find neuroblastoma does not rule this out completely. So if you get a call from a neurologist saying that, I have this patient, there is no neuroblastoma, our advice should be that please keep looking for it. We need to keep serially image the scan, because removal of that tumor will have impact in the overall outcome eventually. Management, as I said, in paraneoplastic tumor removal, along with maybe chemotherapy based on the stage and risk grouping, and immunomodulation, both in the paraneoplastic and the non-paraneoplastic group. So as Praveen said, ACTH and steroids, because of their immunomodulatory effects, are generally the first line of therapy. That is what is used. There is a set protocol for ACTH usage. It can be given intramuscularly or subcutaneously, and usually the course is given over a few weeks to months. Methylprednisolone has been used by some people in a pulse fashion, or an oral prednisolone, and gradual tapering over a few months. Recently, more work has been done on dexamethasone pulses. 3 days pulse of 20 milligram per meter square per day, and give that every cycle for at least a period of 6 months. The challenges are partial response, and again, the relapses happen in these patients as well. Similar stories with IVIG. So usually you give a higher dose of IVIG initially and then put them on some kind of a maintenance. But again, discontinuation of IVIG is associated with relapses in these patients. So this is one of the papers where IVIG was used along with steroids. This was also accompanied with risk-adapted chemotherapy for the neuroblastoma, surgical removal of the neuroblastoma, and all this concoction together helps improve the eventual outcome of these OMAS patients. Some people have also used cyclophosphamide at moderate doses of 25 mg per kg, along with other combination immunomodulation, and that also helps in getting the OMAS symptoms a bit better. But again, we really don't have drugs which are giving a very long-term outcome from the point of view of OMAS recovery, even till date. So this is the protocol that was used in one of the studies where cyclo and dexa was combined, and the eventual outcome in this chronic relapsing OMAS was better as compared to the previous studies. Now comes the drug rituximab, which of late has found more interest in managing OMAS. So as we all know, it is an anti-CD20 drug and removes the B cells, which are the main for the pathogenesis of OMAS. The dose is the same as lymphoma dose, but sometimes we give 4 weekly, 1 cycle, and then may repeat another course later if the child has had good outcome with the first course of rituximab, but unfortunately has a recurrence of the symptoms. One of the latest papers had combined dexamethasone, IVIG, and rituximab together as a combination immunotherapy for these patients, because the stress now is to hit the disease hard in the beginning, to get the immune system under control right from the beginning. And that is what has probably led to better outcomes, better neurological scores in the patients who have been treated in the last decade or so, as compared to the historical controls of patients who were treated for OMAS. Plasmapheresis, cyclosporin, azathioprine, MMF are the other agents that have been tried. one of this upfront immunomodulatory therapy protocol where methylprednisolone was followed by plasma exchange in patients who did not respond, and then they were given higher doses of rituximab 14 days apart, has also found that they were good responses in a certain set of patients. However, it has not been clearly said that one protocol is better than the other. We still are trying to figure out which therapy is better for any particular patient. If plasma exchange is being done, rituximab cannot be given immediately just before that, because the drug may be washed out because of the plasma exchange. So this is another recent paper published in 2019, which again emphasized that early initiation of rituximab with IVIG and ACTH led to better outcomes, so hit the disease hard. There was also a concern that in these young children, when vaccinations are being given, OMS is probably getting triggered back again because of vaccination. However, this study looked at that aspect very carefully and said that the vaccination is safe and there is no relationship with giving vaccine and the occurrence or the outcome of OMS. This is a newer drug which is being tried for the usage in patients with OMAS, and I think there is still time before we can be using this or say that this works well for our pediatric patient and has got less side effects. So I think that would be our talk on OMAS, and we would like to now proceed to low and intermediate risk neuroblastoma if there are no burning questions right now. So Sunil, we would start with low and intermediate risk. Is that okay?
So yeah, Manas, there was a question, unfortunately it's been sent to me. The question is, if a child who needs chemo because of stage, I think the question is, if a child needs chemo appropriate to the stage of his neuroblastoma along with OMAS, can we give these agents which we just mentioned along with chemotherapy?
I think
so. That's the question.
I think, yes. So give the immunomodulation along with chemotherapy and monitor the patient carefully. So we'll be presenting a few cases on low and intermediate risk neuroblastoma. So as already said that, this is a little tricky kind of a disease that pediatric oncologists treat. Always we are struggling with the right classification, the newer risk grouping that comes up. Every day there is new things happening in the imaging. And we have a esteemed panelists with us who are experts in the surgical aspects, imaging aspects, pediatric oncology aspect, and the pathology aspect. And hopefully all of us will try to clarify the common doubts that come to our minds when we talk about low and intermediate risk neuroblastoma. So I welcome Dr. Sandeep Agarwala, Dr. Vikramjit Kanwar, Dr. Mukta Ramadwar, and Dr. Samarjit, who will be the experts here. I would like to acknowledge Dr. Satish Agarwal, who has contributed most of these cases of low and intermediate risk neuroblastoma, and also Dr. Vikram, who has contributed some of the slides. So my fellows will be presenting the cases and I'll be moderating the session. So first case will be presented by Dr. Harish.
Thank you, sir. So presenting the first case. A 4-month-old girl presented with complaints of fever and loose stool since 5 days. The parents had noticed a mass on the left side of her abdomen for which medical attention was sought. On examination of the child was afebrile. BP was more than 95th centile. On per-abdominal examination, abdomen was soft. A mass was palpable in the left hypochondrium and left lumbar region, which was measuring 5 by 5 centimeter and hard in consistency. There were no skin lesions, bony swellings, or abnormal eye movements. On investigation, CBC, renal and liver function tests were normal. Serum ferritin was normal. LDH was mildly elevated. Ultrasound abdomen showed a large mass in the left suprarenal region, measuring 7.9 by 7.1 by 7.4 centimeters.
So the usual case scenario of a young child where a mass has been found, and we now want to know what is going on. What is our clinical impression? So Dr. Sandeep, could you please tell us, what is your clinical impression when a child comes to you with this kind of a situation, an ultrasound report, and how would you proceed? And for our fellows and students, would you like to give any clinical tips as to how we look at the origin of a mass in such a situation?
So are you not able to unmute yourself?
Dr. Sandeep, can you hear me? I think Dr. Sandeep, you can't hear me, is it?
Okay, now I have unmuted.
Okay, sir.
So can we go back on the picture of the ultrasound on the slide, please?
So this is the ultrasound report.
Ultrasound report.
Large
Okay, so now we have a small child with this ultrasound report in the left suprarenal region. The examination is very important in these patients to differentiate clinically what organ is it arising from, and then depending on that the investigation further can be planned. So if it looks like a renal mass, you plan an investigation for a renal mass or for a neuroblastoma in that location, and then other masses. So the first investigation in any case in such a patient would be a cross-sectional imaging, which could be a CT scan or an MRI, depending upon the choice of the treating unit. And that would definitely, kind of tell us which is the organ from which it is arising. Is the kidney free? What is the extent of the disease? And so if we have the the CT scan, we can go on to that.
So clinically, how would you differentiate between a neuroblastoma or a renal mass or other abdominal mass?
So clinically, first in the presentation, the neuroblastoma children are usually symptomatic. They have systemic symptoms. They're not doing well usually, as compared to a renal mass, which is usually a Wilms tumor. They're usually asymptomatic and doing quite well. And on examination, the neuroblastoma masses are usually bossulated, irregular, generally fixed, not very mobile, and you can definitely make out that the features of a renal mass is not present. While a renal mass will have a features of renal mass in the sense they are, bimanually palpable and ballotable. You can often find the colonic band of resonance showing in front of them in large masses. You can usually insinuate your fingers, between the costal margin and the renal mass. And these are the general examination findings. So in addition to the findings and the clinical picture, you would think in terms of either of the two common diagnoses. In addition, if you have other things like bony pains or the child has stopped walking or is having difficulty in walking, that definitely points towards neuroblastoma as compared to a hematuria, which will point towards a Wilms tumor. So these are generally clinical pointers which will point towards either of the diagnosis, and then we can start working on the patients in that.
Sir, what about the crossing of midline concept? That has always been told to us. In India, what do you think?
So crossing.
Do we get very large? Yeah.
So crossing of midline concept is not there. I think in India it is absolutely not there. Even a renal tumor crosses midline, and actually the difference is when you look at the CT scan. Is it crossing midline, overhanging the major vessels, or is it encasing the major vessels, or is it pushing the major vessels? A Wilms tumor usually tends to either overhang the major vessels or push it, but does not encase it. On a CT scan, if the tumor is encasing, or there are multiple nodal masses in the retroperitoneum encasing the major vessels, it points more towards neuroblastoma. So clinical examination, overhanging of the midline is something which is not very significant, at least in the Indian context, and we cannot, it can be in either of the tumors.
Dr. Samar, we went ahead and did the imaging of this patient. Would you like to just comment on the images of this child and tell the audience what you feel this is?
Well, you see a large heterogeneous lesion in the retroperitoneum to the left of the midline. I wonder if you can you see the pointer? Yeah? Is the pointer visible?
No, it's not visible. I will put the pointer. I'll try to put the pointer. I'm not sure if at the right spot, but I'll try.
And there are areas of calcification within it anteriorly actually, which would have been better seen on the plane scan. And you can see, as Dr. Sandeep just said, it is encasing the aorta and it is encasing the origin of the major vessels, which is the celiac axis. Just hang on. I think it's not audible because of the mask.
Yeah, probably, yeah. Better without the mask.
Oh. All right.
Thank you.
Okay, so there is a large mass in the retroperitoneum, as you can see, which has got calcification within it in a young child, encasing the major abdominal vessels, including the aorta. It is retroperitoneum for sure, because you can see anterior displacement of the pancreas, which is the retroperitoneal organ. Young child presenting, like you just said, with the retroperitoneal mass showing calcifications, encasement. The kidney is separate. It is displaced inferiorly. You can see there is almost a plane between the mass and the kidney, which is telling you it's not a renal mass, not arising from the kidney. In which case, our first diagnosis would be a neuroblastoma. And this is an angiographic view which we do for variant vascular anatomy or vascular encasement. And in this case, you can see actually that the left hepatic artery is arising from the left gastric artery, arising from the celiac axis, and the common hepatic artery, which divides into GD and RH, is replaced as a direct branch from the aorta. This really helps the surgeon when they're doing surgeries, planning a surgery to see whether they can remove it or not, right? Again, it is the same view, just a little lower down to show you that the SMA is abutted. So I just wanted to tell you the difference between abutment and encasement. If there is more than 180 degrees involvement of the artery, we say that it is more likely to be involved, or 360 degrees totally encased. But if it is just touching the artery with less than 180 degree of involvement, we just call it abutment, and that doesn't come into the IDRF. So you are asking me about the imaging defined risk factors. It is, except for the fact.
That's fine. That's the next question. What are image defining risk factors? And how do we go about them when we see our patients with neuroblastoma?
Yeah, so IDRFs for us, basically, if it is in more than 2 body compartments, that is either it is in the, so there are 4 compartments: neck, chest, abdomen and pelvis. So if it is more than 1 compartment, neck and chest, chest and abdomen, or abdomen and pelvis, we call it a positive or a IDRF is present. Then of course, whatever causes a problem to the surgeon in removal, let's put it that way in the simplest terms. There is a whole list obviously, which you can look at theoretically, but practically speaking, wherever you feel that the surgeon will not be able to remove the tumor, where it is involving a structure which is vital, that is the base of the skull, the IJV, the carotid artery, the trachea, the brachial plexus, the aorta, the IVC, the superior mesenteric vessels, root of the mesentery, the pelvic vessels, all these structures, wherever you feel, porta hepatis, wherever you feel that there is an involvement of a major structure, we say that then IDRF is positive, right? There is also involvement of the spinal canal, which is more than 1/3 of the circumference should be involved in the axial plane, etc. So that is also an IDRF. Some people say when that is the only thing that is present, they don't sometimes call it an IDRF, but otherwise, theoretically speaking, if there is more than 1/3 involvement of the spinal canal, it is supposed to be an IDRF. So net, wherever you feel that there is involvement of a major structure, or encasement of a major structure, it is an IDRF. As far as veins go, if there is compression of the vein with obliteration of the margin, it is an IDRF. If there is an indentation of the vein with just narrowing, that is not an IDRF.
So, Dr. Mukta, if you are here, an ultrasound guided biopsy of this child was done for this abdominal mass. If you could just tell what we can see in this image of this patient and what does that mean to us? Dr. Mukta?
I think you will have to unmute her. The organizers have to unmute her. She's there on the list. Organizers have to unmute her.
Ria?
Yes, sir, she's unmuted. I have asked her, since she's a co-host, I can only request.
Yeah. Ma'am has sent a message saying please unmute.
No, she.
Oh, can you hear me?
Yes.
Yeah,
yes, ma'am, we can hear you.
Hello?
We can
Hello?
hear you.
Yeah, okay. Great. Somehow I wasn't able to unmute on my own. It said that the host had to do it. So is it okay now?
Yes, ma'am, we can hear you.
Yeah. Okay, but the screen has gone. Can you see the screen? I can't see the screen.
We can see the screen, ma'am.
Probably joining in again would help.
Yeah, right. What we are seeing here on the screen is basically we have to start with understanding that this is a small round cell tumor. That means it's an embryonal tumor. Like unlike in adults, this is not a carcinoma, this is not a spindle cell sarcoma, not a melanoma or a lymphoma. But this is an embryonal tumor, which is composed of these small round cells. You know, I know most of you don't look under the microscope. Like all of you are very well versed with imaging, be it X-ray, MRI, or CT scan. Somehow you don't have the acquaintance with the microscopic images. So I'm just trying to explain what the terminologies are used in the pathology report and what it means. It's a transcription of what we see under the microscope in the report. So this is a neuroblastoma, which is composed of small round cell tumors. So these are embryonal tumors with very little differentiation. But when I say little differentiation, it's not absolutely true, because can you see this blue stuff here, the round blue stuff? This is a neuroglial tissue. And neuroglial tissue in a small round cell tumor happens in only two conditions. One is a neuroblastoma and another is
I think ma'am got disconnected. Is that right?
Ma'am is still online, but
sorry, there is. So neuroblastoma, which I would label as poorly differentiated neuroblastoma, which is stroma poor. That means there is no Schwannian stroma. This is not a Schwannian stroma dominant neuroblastoma, and it is poorly differentiated. That means this is not undifferentiated neuroblastoma. We can still recognize by the presence of neuroglial tissue that this is a neuroblastic tumor. Had this been an undifferentiated neuroblastoma, we would not see this, and all we could see was the just the sea of small round cells. So this is a stroma poor. That's the first step. Second step is poorly differentiated neuroblastoma. And the third thing that I want to see in this field is how much is the mitotic karyorectic index. And I can see that it is pretty much low. I do not see any mitotic or karyorectic figures. So this is a neuroblastoma, which will turn out to be of favorable histology in an infantile age group.
So as ma'am said, that this is a so as ma'am said, this is a stroma poor neuroblastoma It is poorly differentiated. The important thing was that there is neuroglial tissue. So that makes it like a neuroblastoma along with the small round cell, and the MKI index is low, and there is less of stroma, and this is favorable histology according to the INPC classification. This was on the biopsy. Ma'am, immunohistochemistry was done on this patient. And would you like to comment on immunohistochemistry in such a situation?
Yeah. See, let's talk about this particular case. If I'm looking under the microscope, in the first 2 seconds, to me, it is very, very clear that I'm looking at a neuroblastoma. In a suprarenal location, this is the biopsy, it is a neuroblastoma. So I do not have any diagnostic issue here. So when is immunohistochemistry required in a neuroblastoma? There is only one answer to this question, and that is when the
One of
Ma'am has got disconnected.
I think what ma'am was trying to say was that in a classical situation, we do not need immunohistochemistry. And if we are very sure that there is a neuroblastoma-like situation, then, you know, doing a IHC is not really required.
Yeah, so no, and this is only the part of it. Now I will actually go to the main point. Why do we not require immunohistochemistry? One is not required diagnostically in such cases because it's very rare. And secondly, and much more importantly, we need to preserve the tissue. We do not want to, these are very small precious biopsies. We do not want to lose the tissue because there are much more important things like doing the NMIC, doing the MLPA, which lies ahead in these children for risk stratifications. So the tissue is of utmost importance. If you are triaging the tissue at the time of biopsy, if you have adequate tissue, go ahead and do it, even if it's not required. But I refrain from doing immunohistochemistry in straightforward neuroblastomas and save the tissues for molecular testing.
Ma'am, you were saying that there is one situation where IHC may be needed. What was that situation?
Yes, and that situation is in an undifferentiated neuroblastoma, where I don't have any neuroglial tissue. I can't make out that this is a neuroblastic tumor. So although I'm highly suspecting it because of the location and the other radiology findings, but still a straightforward histopath diagnosis may not be apparent without immunohistochemistry. And there is second difficult situation for us wherein it's a large tumor, suprarenal tumor, and the distinction between a Wilms tumor and a neuroblastoma is difficult. So this is a second scenario where I would go ahead and do immunohistochemistry.
So ma'am, what will be the IHC markers that you will use? If you can just quickly tell us.
Yes, so synaptophysin is one. I will be extremely selective in this panel. One is synaptophysin. Second is WT1 that I would expect to be positive in only a proportion of Wilms tumor. And A1, A3, which is an epithelial marker. Again, I would expect it in a Wilms tumor. So honestly speaking, synaptophysin is the only marker which is useful in neuroblastoma. The other two are for the Wilms tumor. And if I'm thinking about, say, rhabdomyosarcoma sarcoma or a peanut, then I would use those immunohistochemistry markers depending upon the morphology. Not always.
So ma'am, what is this INPC classification and how is it important to us?
Okay, so again, as I'm saying, let's get acquainted to histopath histopath terminologies. This is the basic classification of how a pathologist classifies a given neuroblastoma. Okay, so the classification is, wait a minute, can we go a slide further? Just a slide ahead. Can you move? Yeah, okay. So now the category in the red box, it's a neuroblastoma Schwannian stroma poor. It is this category versus the others. And this basic distinction determines the clinical course of the disease. Okay, it is absolutely like, go back please. Go back to the first slide. So it is the Schwannian stroma poor neuroblastoma versus Schwannian stroma dominant neuroblastic tumors. Can you go back, Manas, please, one slide? Yeah, okay. So depending upon how much is the Schwannian stroma, this classification begins. And within this category of neuroblastoma, Schwannian stroma poor, there are 3 more categories, which we will be just talking about in the next slide. But essentially, what it shows is the ganglioglial differentiation is less than 50%, okay? And there is minimal stroma. In the rest of these categories, which include ganglioneuroblastoma, which is intermixed type, ganglioneuroma, and then this interesting category of ganglioneuroblastoma nodular. Herein, we have more than 50% of ganglioglial differentiation. So the classification of neuroblastoma begins at this stage. What is the amount of neuroglial tissue and how much is the amount of Schwannian stroma? That is where it all begins. Okay, and the next slide, please. Please. So the category in the red box, that's going to be categorized further. Can we move ahead? One slide.
Next.
Next slide, please. Yeah. So this is an example of a Schwannian stroma poor neuroblastoma, which is poorly differentiated. And this is also a stroma poor neuroblastoma, but this is differentiated because this is showing a lot of ganglion cell differentiation to me, but still that differentiation is not more than 50%. Okay, so this pathology differentiation is incorporated into International Neuroblastoma Pathology Classification. This was introduced in 1984, and let me tell you, it is still valid clinically. So what it does is, it simply incorporates histopath findings, which are what is the type of this neuroblastoma, what is the MKI, and what is the age of the patient. This does not incorporate any biology. There is no mecan, there is nothing else. It is just the basic biology, basic histology. That is, what is the category of neuroblastoma? If it is stroma poor, what kind of stroma poor neuroblastoma it is, and how much is the MKI. MKI is the mitotic karyorectic index. So in here, there are two bad news. One is a child which is less than 18 months of age having undifferentiated neuroblastoma with and high MKI, and another is a child of more than 5 years old, any histology and any MKI in a stroma poor neuroblastoma. So this is the INPC classification. Even if we do not have molecular test with us, this is still a very robust risk stratification system, which includes, but that is most important, that you have to know how to classify the neuroblastoma under your microscope and how to incorporate into INPC classification.
So broadly speaking, an undifferentiated tumor, a high MKI, and older age groups makes it unfavorable kind of a situation. So now we have looked at the histology of the patient. We know what the basic disease was. We have seen the CT scan. Dr. Vikramji, how would you like to stage this patient?
So staging basically is maybe unfortunately derived from worst case scenarios. So you end up doing the imaging, which Dr. Sandeep just described. You want to do CT or MRI for the local tumor and to see if there's spread, usually in small children, that'll typically end up covering both the abdomen and the thoracic area for any kind of more distal sort of spread. You also want to do an MIBG scan if it's available, but in India, we don't have access to MIBG isotope. So typically we end up doing a PET scan instead. You want to do a bone scan to complement that if you have the resources. And you want to do bilateral bone marrow aspirate and biopsy, determine the nature of whether there's involvement or not of the marrow. So you want to do
investigations other than these basic staging investigations. Right. Would you like to do any other investigations?
So your ferritin and LDH are good markers for risk. So patients with elevated LDH, elevated ferritin are often considered higher risk. Urine VMA, HVA, obviously you'll have done already to document. This is a neuroblastoma. And CBC and basic chemistries, if it's a patient where you are considering chemotherapy or other treatment. So at least a CBC and potentially then chemistry to go with that. And so
Dr.
it's a
Vikram,
long
if
laundry
you're
list.
doing a MIBG scan, if you're doing a MIBG scan or a PET CT, would you still want to do a bone scan? Or, you know, that's probably, if you have done a good metabolic screening and your primary disease is FDG avid, would you still want to do a bone scan?
If it's a patient who's in a high risk category or you suspect is high risk, then yes, you should do a bone scan because it will pick up lesions which may not pick up on PET CT. But for other patients, no, because you're unnecessarily exposing the patient to extra investigations, radiation, et cetera, et cetera.
Okay, actually, we have not been using a bone scan to complement the MIBG or a PET CT. Sometimes, you know, even the MIBG scan will show you so many bony lesions. And
Right.
you know that is
exactly. And this, and I should clarify for the students, like sometimes what is preached in the what we should do world and what we do practically day to day is often there's a variance. So personally, in my own experience, if I'm doing an MIBG or PET scan and I have positive results on that, a bone scan is going to be overkill. It's not going to give me extra information to change our management. And that's a good point you're making.
I would like to highlight the PSYOP-ODC guidelines where they said that, you know, if you have a FDG, an LDH which is above 750 and a ferritin which is more than 120, this might be a surrogate marker for anemic amplification in stage 3 patients. And, you know, you might want to treat them like a high risk case. And stage 4 a metastatic disease is anyways a high risk disease. So even if they are MIC and not amplified in an older age group, they're anyways treated as high risk. But today's topic is low and intermediate risk, and we'll try to focus on that. So coming back to our patient.
So we did the urine vanillin mandelic acid, which was elevated, and bilateral bone marrow biopsy was done, which was normal.
Right, yes.
So this graph just shows that HV and VMA are the final byproducts of this whole tyrosine metabolism. This tyrosine hydroxylase is overexpressed in neuroblastoma patient. So if you just do a spot HV and VMA, that is enough, and you don't have to screen the entire catecholamine pathway. And this will help you to even monitor the patient later. And this is what we commonly do as a spot urinary catecholamine test. And in our patient also, this was elevated. So we did a PET scan for this patient just to look for metastatic disease. And we found the abdominal disease. It is seen to be FDG avid, and there was no disease anywhere else. There is a huge abdominal mass, which you can see with the image defining risk factors that were already positive. So, this is where we are. So I would like to ask Dr. Sandeep Agarwala to comment upon the staging system of neuroblastoma. After you have done all these investigations, you know what your patient has. How would you stage this patient? The older way, and what is the newer way of staging these patients of neuroblastoma?
Okay, so as you said, older way and the newer way. The older way is INSS, International Neuroblastoma Staging System. It's basically a surgico-pathological staging system. And as you can see in the staging system, you can only have stage 1 and 2 tumor once you have resected, because it says stage 1 localized tumor with complete gross excision, and stage 2 is localized tumor with incomplete excision. So the patients, a lot of our patients will automatically fall into stage 3 or stage 4 if they are metastatic. So if you just done a biopsy as was done in this patient, probably for the INSS, it will be stage 3 irrespective of any other thing. But in this, we have the tumor crossing the midline, infiltrating across the midline. So it is INSS stage 3 and it is non-metastatic. So it is stage 3. In the newer classification, which is the INRG, the International Neuroblastoma Risk Grouping, which is basically classified into L1, L2, M, and MS. This is based on radiology and is not based on the surgical excision. And so all tumors which do not have IDRF, that was already discussed, or are IDRF negative are L1 tumors. Tumors which are locoregional and have IDRF positive in any of the factors are L2 tumors. Metastatic tumors are called M. And MS is that special category which used to be called 4S. The age has been increased to 18 months instead of 12 months, with metastasis confined to skin, liver, and bone marrow. We must remember this. So this tumor would fall into L2. So INSS stage 3 and INRG stage 2. That would be the staging for this tumor.
Thank you, sir. So after the staging has been completed, how would you risk stratify this patient for the decision of treatment? Dr. Vikramjit, would you like to comment on that?
Sure. Risk stratification is always a fun topic. So the key thing is age to start off with. You also want to look at the group or the stage. In addition to that, depending on which protocol you're following or which staging, which group protocol you're involved with, the INPC pathology is relevant. And then tumor genomics, especially NMIC amplification, but also loss of heterozygosity of 11q and ploidy status, or segmental chromosomal aberrations, depending on whether it's US or European studies. So this gives you a good sense as to what the various kinds of risk stratification end up being. And basically, you can end up with 4 categories: very low risk, where your expected event-free survival is 90+%; low risk, where your expected event-free survival is at least 80%; intermediate risk, where overall survivals may be high, but the likelihood of needing extended chemotherapy is significant. So event-free survivals are often 50 to 75%, and high risk, where your EFS is definitely less than 50 and often more like 30 to 40%. So this is the grand kind of, so this I think is the Children's Oncology Group, also the NIRG pre-treatment classification. The problem was this was put together by many, many different people. So yes, it works as its whole, but the challenge is, in order for it to be meaningful, every piece has to be accurate. You have to have good INPC pathology, you have to have good genomics, you have to have an NMIC status, and then you can use it to risk stratify how you treat the patient.
So for our patient who was less than 18 months of age with the L2 INRG stage, and the histology was none of these, the NMIC was not amplified, the patient could be classified into low or intermediate risk category.
Correct.
So we thought maybe it's a low risk neuroblastoma, left suprarenal mass, IDRF present, L2, NMIC negativity. How do we decide further therapy in this patient? So we looked at the CCLG protocol, and we looked at what we do for L2 patients who are less than 18 months of age, who are NMIC non-amplified. So it comes into the low risk category because there were some life-threatening symptoms present in this patient, and we chose to give chemotherapy to this patient with carboplatin and etoposide. So the life-threatening symptoms have been very clearly listed, and you can get that list from the CCLG protocol, and hypertension is one of them, which were present in our this particular patient, and all the other life-threatening symptoms like gastrointestinal, respiratory, tachypnea, everything has been mentioned very clearly, and this helps us to take a call as to whether this patient requires chemotherapy or not. So this patient was given neoadjuvant chemotherapy with carboplatin and etoposide, did develop acute gastroenteritis, required amlodipine for the hypertension part, and after 4 cycles, an angiography was repeated. Dr. Samar, would you quickly just comment on what this shows? Just very quickly, please.
Yeah, again, you can see that there is still encasement of the vessels, but there is reduction in the size of the lesion. This is post-treatment. So you can see there is significant reduction in the size of the lesion. The vessels are still encased. They are still surrounded 360 degrees by the lesion. However, as you can see, there is reduction in the size. Right?
Okay. So a multidisciplinary team meeting was held for this patient, and we, discussed with our surgeon. And I don't know if Dr. Satish is there, but it was decided to give 2 more cycles of chemotherapy, and then, again re-look at it for the surgical resectability. Dr. Samar?
So again, the surgical resectability, we are not generally looking for an R0, but we do want to see that if we will have to, if we will come across any surprises like variant vascular anatomy, or if the renal vascular channels will be endangered. In this case, again, you can see that this is a plain scan basically showing that the calcification in the lesion has increased and it has reduced in size. I can't really comment on the vascular encasement in this. However, you can see that depending on the location, it must be involved because the lesion is so closely related to the anterior aspect of the aorta, where the vessels come off.
So this child underwent a laparotomy and excision of the mass. And Dr. Satish, would you like to comment on this child's surgery?
Thank you, Manas. Hi, Sandeep. Hello, everyone. I mean, if I remember correctly, this child had a difficult tumor excision because of the vessels being very close to it, but it was calcified. And the plane between the kidney and the tumor could be created very well. And then we had to follow the vessels in order to save them, especially I think the celiac or the superior mesenteric, I can't remember. The celiac was kind of, as Dr. Samar said, it was abutting the tumor, and there was some difficulty there. So I might have left about maybe 5% of the tumor along the celiac, but rest of it was removed and the kidney was safe. And that's it.
So the biopsy of this mass was a neuroblastoma differentiating. Dr. Vikramjit, would you like to comment on how would you follow up this patient who has received chemotherapy followed by a surgery, and the tumor is now almost out?
So this is somebody you need to see back in clinic roughly every 3 months. As far as imaging goes, it is probably not unreasonable to follow by ultrasound rather than doing multiple CT scans or MRI. You want to check a urine spot VMA at each visit, which may give you a guide as to if there is recurrence. And since the patient has received chemotherapy, it's not unreasonable to check a blood count at follow-up. But in general, the main thing you're looking at is any evidence of recurrence. The patient received KDO, so probably about a year post chemotherapy, you should check an echocardiogram. And any recurrence or progression is going to take place in the first 2 years. So once you're about 2 years out from completion of treatment, you can back off on frequency of follow-up, as well as any kind of imaging, etc. But you probably keep them under your follow-up at least till they're 4 or 5 years of age.
So the expected long-term follow-up for this patient, our long-term outcome is more than 90%. It's a low-risk neuroblastoma. Hopefully this child will be cured. So we'll now move on to the next case scenario.
Manas, can I just chip in with one comment?
Yes, ma'am. Yes, ma'am.
The post resection, or in this case, post chemo resection, we do not apply the histologic prognostic parameters to post chemo excision specimens.
Sure.
So the risk stratification is entirely on the chemo-naive, either biopsies or resections.
Yes, yes. So we'll quickly go on to the second one. Dr. Swati will be presenting this.
Thank you, sir. So we had a 4-week-old male baby, term born, presenting with complaints of cough and high-grade fever with repeated convulsions. He was admitted in a local hospital and given IV antibiotics. The chest X-ray done for these complaints was suggestive of opacity in the right apical region. The CT chest suggested well-defined, minimally enhancing, homogeneous soft tissue mass, measurements being 3.2 into 2.7 into 2.6 centimeter, involving right side of the posterior mediastinum.
Dr. Sandeep, what are the DDs of these posterior mediastinal masses in very young children? What would you think when such a child comes to you?
So, posterior mediastinal masses have very interesting pathologies. So, if we look at cystic masses and solid masses in this young child, obviously neurogenic tumors are the first most common, but then you can have teratomas, which are usually anterior mediastinal. But if they are large, it is difficult to differentiate from the posterior mediastinal ones. You could have other things like duplication cysts, which are totally benign. And the marker to that is the presence of a vertebral anomaly. If it is present in an X-ray chest, we would think of a duplication cyst, a foregut duplication cyst. Then you could have lymphangiomas, which could again be in this location. In older babies and older children, you could have any of the other things like a hydatid cyst or things, benign things like that. But in this child, in a small child, I would put neurogenic tumor and then maybe a teratoma, and also consider the duplication cyst, even if the vertebral anomalies are not present. But since this is a solid mass, you would restrict the diagnosis to a couple of pathologies.
Thank you, sir.
So on examination, the child had a heart rate of 138, was not tachypnic for age. BP was 80/50. The weight of the child was 3 kg. Systemic significant findings were the air entry was reduced in the right upper zone. Rest examination was normal. We investigated this child and found that CBC, renal function and liver functions were normal, but the serum ferritin was significantly elevated. The LDH was 242 international units per liter.
Dr. Samar, can you comment on these images of the MRI of this patient, little baby with this posterior mediastinal mass?
Yeah, so basically this appears to be a sagittal, parasagittal rather T2 image on the left of the screen, and it's somewhat hyper intense on the T2 weighted images, which you can see it's T2 because there is fluid in the brain structures and the gallbladder. Right? Can I see the next slide? Yeah, so these are axial images, and you see that it is located near the apex of the lung. It is abutting the vertebra, but there is no intraspinal extension. It is just reaching up to the trachea. There is no compression of the trachea, so there are no IDRFs in this lesion. So there should be an L1 lesion and no intraspinal extension. And like Dr. Sandeep just said, solid mass in the posterior mediastinum. The first thing would be a neuroblastic tumor. Rarely we get weird things like peanuts here sometimes.
Dr. Satish performed the right posterolateral thoracotomy in this patient, and the tumor was excised in toto. There was no extension in the spinal canal, no vascular encasement. If such a child presents to you, Dr. Sandeep, would you straight away take this child for surgery, or would you consider doing a biopsy first?
So in this child, he's just 4 weeks old. There are two things to consider. You said the report, the ferritin was high and the LDH was high. And we have already discussed that these are markers, surrogate markers for NMIC amplification. So we are looking at something which probably may have NMIC amplification. So I would consider this in two aspects. One, a tumor which has NMIC amplification and which does not have NMIC amplification. We know very well that such tumors which are not high risk in small children can spontaneously resolve also. So we would have followed up this patient because there was no respiratory distress in this patient. The rate was normal, and we would have just followed up this patient to see if the tumor is growing or is going down. As the question of biopsy comes, maybe, but then I would consider what Dr. Satish did was a biopsy itself, because if you do, it's a small tumor and a surgeon feels it can be removed very easily without much complications, then that itself becomes an excision biopsy and gives you feed for the further management of this patient. So you can go either way. You can go either way in this patient.
Would you like to comment on the biopsy, please? Just very quickly.
Yeah, so it looks very much similar to the earlier case. So this is again a small round cell tumor which is rosette forming. So the only difference here is that lot of other differential diagnoses also come in because of the location of the tumor. Like, is it a neurogenic tumor, or is it a teratoma, or is it a neuroblastoma? And the most importantly, is it a peanut? Although in this age group, peanut is rare, but morphology would be exactly similar. So in this case, my immunohistochemistry would be put in, and markers for peanuts would be addressed here, just because of the overlapping morphology.
Sure.
But this is a poorly differentiated. Yeah. So this is a neuroblastoma, which is again stroma poor, poorly differentiated, low MKI, and favorable histology.
So the NMIC came out to be negative, not amplified for this patient. Ma'am, would you like to comment what is beyond morphology, just very briefly, and how that is important for neuroblastoma?
Yeah. So INPC stops at only morphology, and obviously that wasn't enough for neuroblastoma. And the biology in neuroblastoma started with recognition of NMIC amplification, which till today is the most robust biologic prognostic marker. And if we look at the INRG chart, can we have the INRG chart here again? That would be very relevant, because Manas, do we have the INRG chart here?
Yes, ma'am, we'll get it for you.
Yeah, that's because it just keeps the entire thing into perspective. Here I don't see, okay, so there are these three things: Meccan status, 11q aberrations, ploidy. 1p deletion is still not in INRG, but that also is a prognostic marker. So beyond the morphology, these three things come into play. So what that means is, even if the Meccan is not amplified, if you have 11q aberrations and the ploidy status, then in spite of NMIC being non-amplified, these children can be stratified, the risk stratification can be upgraded to at least intermediate grade based upon these parameters. But now, if you read the literature, we have even today gone beyond these three biologic parameters. There are many more molecular biomarkers which are indicators of bad prognosis in neuroblastoma, and that is tested on different platforms. This is one image where it is a FISH testing where we can see Meccan amplification in the tumor cells. The green dots are the FISH dots of the Meccan gene, which is amplified. And this is a normal Meccan non-amplified neuroblastoma.
So Meccan amplification is associated with advanced stage of disease, and we'll not go into the detail of that because we are going to discuss this definitely whenever we are talking about high-risk neuroblastoma. So Dr. Vikramjit, is there a role of an adjuvant chemotherapy in non-Meccan amplified stroma poor differentiating tumor?
Well, like everything else in neuroblastoma, it depends. So in this case, I would say no. Like, this is a thoracic neuroblastoma, which in general tend to have good outcomes. Age is young age, and NMIC non-amplified. We don't know what the ploidy status, segmental chromosome aberrations are, but I'd be comfortable just monitoring and following rather than jumping in with adjuvant chemotherapy. So I would say, having done surgery, observation only would be appropriate.
So this is really a L1 tumor, did not have image defining risk factors. The tumor has come out fully. Meccan is not amplified. So we would be just happy in observing this patient. The third case scenario, I'll just go through that very quickly. It's a 6-year-old male child with a lump in the abdomen. And, the images are very clear here. We can see that, there is this big mass, which is very clearly visible, very well circumscribed. And I'll just go through this quickly for the lack of time. And this whole mass was, the MIBG scan did not show any uptake anywhere. There was a well circumscribed suprarenal mass, and the whole mass was removed. And after the mass was removed, It showed that it was an endemic non-amplified neuroblastoma. And we can see these images of this full mass which has been excised. And the histopathology was suggestive of a ganglioneuroma. So this is again the other spectrum of this illness. We have seen two different types of neuroblastomas, one low risk and one which is completely resected, which is L1. And this is the other spectrum where again, there is only ganglioneuroma, complete resection of the mass, and no adjuvant therapy given, no just an ultrasound as a surveillance scan, and the child is doing really, really well 5 to 6 years post treatment. So this is just one case I wanted to highlight. Now we'll move on to the next case, which again, has got some interesting discussion points in it. And Dr. Divij will be presenting this case.
Good afternoon, everybody. So I'm presenting a case of a 3-month-old female hailing from Assam who presented to us with multiple nodular swellings all over the body since the last couple of months. This was associated with abdominal distension, which progressively increased when the parents noticed it. USG abdomen was done outside, which was suggestive of hepatosplenomegaly with a retroperitoneal mass. All antenatal scans were normal. On examination, there were multiple nodular swellings all over the body. There was abdominal distension and hepatosplenomegaly. As you can see in these images, there were subcutaneous nodules. I'm very sorry about the poor quality of the image. They were more palpable rather than inspectory findings. So they were present throughout the body. Investigations were CBC, LFT, and KFT were normal. USG abdomen revealed a retroperitoneal mass with multiple calcifications, which were encasing the retroperitoneal vessels and involving the left renal hilum with liver mets and mets underneath the anterior abdominal wall and lymph nodes. Urinary HVA was elevated. It was elevated. Ferritin and LDH were high, but they were not very high as per our expectations. PET-CT was done at diagnosis.
Dr. Samar, could you just comment on the PET-CT of this child who's got disease at multiple sites in the body, a very young baby with disease at multiple sites? Can you just comment?
Sir, Dr. Samar had to go somewhere. He's coming in 2 minutes.
Okay. So, I can just show the metabolically FDG avid areas. We can see something going on in the abdomen, something in the thorax, even in the neck. And also there were some subcutaneous and omental nodules, which were FDG avid. I don't know if my pointer is visible, but we can see all these FDG avid areas, even in the omentum. And this is the mediastinal area where again, there was an FDG avid paraesophageal lymph nodes which were present. So we can see, on both the sides of the diaphragm, we have a lot of FDG avid lesions, subcutaneous, omentum, and lymph nodal masses. And this is the description, and I'll just skip through it. Dr. Mukta, can you comment on the biopsy findings in this patient?
Yes. So malignant round cell tumor, no doubt about that. And I can see minimal neuroglial tissue here, but it is good enough for me to tell that this is a neuroblastoma. And the mere presence of neuroglial tissue tells me that it's a poorly differentiated neuroblastoma and not an undifferentiated one. And even on this power, I guess, the neuroglial tissue is very well evident in this image. And the MKI looks like it's low. So again, it's a stroma poorly differentiated neuroblastoma, low MKI. I would put it as a favorable category in our 3-month-old child.
So IHC was run on the biopsy specimen, which was positive for synaptophysin, negative for LC and Wilmsdorfer 1 gene. CD99 was focally equivocally positive, and a Ki67 proliferative index of 40 to 45%. NMIC was run on the biopsy sample. It was negative. Bone marrow biopsy did not show involvement by the disease.
So I would want, all of you are seeing this patient. It's an interesting case with this disseminated disease. So I would request everybody to have kind of an impression of how you would risk stratify or stage this patient. Dr. Sandeep, what do you think? What kind of illness this child has?
So very interesting. You see, at the outset, if all the students can see, and they would probably call it stage 4S because of the subcutaneous nodules and the mass in the abdomen and a small child. But you have to be careful. The 4S or MS definition says metastasis to the skin, bone marrow, or liver. But this child has metastasis to mediastinal nodes also. So two compartments involved, mediastinal nodes are also involved. So this would be a metastatic disease. So it would not be 4S, it would be M. And then we have to look at the risk stratification for this patient. It could be high risk, or if you go back to the risk stratification, then we will see that it could be high risk or intermediate risk, even with metastatic disease. So metastatic disease, if it is less than 18 months, NMIC, if it is amplified, then it is high risk. If it is not amplified and other parameters are also negative, it becomes very low risk for MS. But in metastatic disease, for a small child who's less than 18 months, again, as I said, it could be intermediate risk or also high risk, depending upon what markers we get positive, NMIC and other chromosomal status. So it will probably need treatment as the metastatic disease, and then we can decide whether intermediate treatment or high risk. But as it is being presented in an intermediate and low risk conference, I would say that they're thinking of intermediate risk in this patient.
So that's right. We thought of an intermediate risk neuroblastoma, a metastatic disease in a child who is less than 12 months. NMIC is not amplified. We did not have access to ploidy or the 11P. So we kind of took it as, intermediate risk patient. And if you really look at the CCLG protocol here, and if you have a metastatic disease in a less than 12-month child, and you are NMIC not amplified, you are usually treated by an intermediate risk kind of a strategy.
Yes.
And when we look at the COG protocol as well, which we normally follow at our center for managing intermediate risk neuroblastoma, this child was kind of fitting into the group 4 category. And in infants, such a disease is kind of well known. So we decided to use this is the COG, it classifies into group 1, group 2, group 3, and group 4. And this child came into a group 4 kind of a category and requires 8 cycles of chemotherapy to treat the patient. So this child was started on a COG based protocol, and we decided to give 8 cycles of chemotherapy. After 4 cycles of chemotherapy, we repeated a scan because there was such a extensive metastatic disease. Normally for surgical aspect, we use a CT scan, but in this particular patient, because of the extent of metastatic disease, we did a PET CT. I don't know if Dr. Samar is here and if he could comment on this, but from my understanding, the metastatic lesions kind of completely disappeared. Most of the metastatic lesions were gone, just with 4 cycles of intermediate risk kind of a strategy. The child had limited disease, but the surgical aspect, it was still, there were some image defining risk factors were still present. The mass was still big. It was still encompassing the abdominal aorta and its branches, although all the metastatic lesion showed a near CR in this patient. Dr. Satish, would you like to comment whether you wanted to do surgery or you wanted some more chemotherapy at this stage? I think you wanted some more.
No, I think because it was still resolving and the child had received some chemotherapy and the tumor was responding. So we together thought it better to continue for some more, maybe two more shots of chemotherapy and then reassess for resectability.
So Dr. Sandeep, what would be your opinion in such a child where we have kind of decided to give 8 cycles? Would you want to give more chemo or straight away take up for surgery after 4?
I would not take up for surgery after 4 cycles because the image defined risk factors are still, positive, and it would be very risky. We can get into a problem of, chyle leak and other problems which would delay the further management of this patient in terms of chemotherapy. So I would agree and go with further chemotherapy to this patient and then see how it behaves. It is good that the metastatic disease has disappeared, but the local disease, I think, is too risky to, go for surgery at this point of time.
So here's the question for the surgeons, which I've always had, that if you give 8 cycles of treatment according to intermediate risk protocol, and at the end you have, say, only about 20% of residual disease, but it's still basically wrapped around a lot of vessels. would you just leave it alone, or would you attempt to resect anything from that? And I don't think there's a right or wrong answer. I'm just curious because different surgeons have different approaches.
Center, yeah, very interesting question, Vikram. In our center, we would leave it alone and just follow the patient.
That's my approach as well.
Because most
but
of
I'm not
it,
sure everybody does that.
Most of it would be calcified.
Exactly.
And risky to remove it. But I know centers where they would remove it. In Japan, in La Quilca centers, and also in Great Ormond Street, they would still attempt.
Yep. Oh yes. Yeah. You're absolutely correct.
So 2 more cycles were given as per our discussion in the multidisciplinary team. Dr. Samar, would you like to comment?
Yeah, again, you see there is reduction in the size. However, there is still encasement of the aorta and its major branches. And again, you see there is reduction in the size, calcification, and encasement still persists.
So at this point of time, we had a discussion about the safety of the surgery with the family, and Dr. Satish was involved. So would you like to comment?
So if you go back to the imaging, I was, go back to the imaging. So one more, another one. Yeah, if you look at here, no point now. So the vessel encasement is still there, but then a large portion of the tumor is lying behind the splenic vein and to the left of celiac axis. So what we did was we lifted the spleen, the stomach, and the pancreas all together and just shifted onto the other side, just like turning a book page, and then carefully dissected this tumor first away from the kidney, which we were able to do it, and then shave it off from the vessels. The splenic vein dissection was a bit difficult, but ultimately we could remove entire tumor to the left of the celiac axis.
So the child, the post-op period was uneventful, and the biopsy of the mass showed, ma'am, any comments on the biopsy?
So this is a stroma-rich tumor. But see, now that's the point I was making earlier on, that this is a post-chemotherapy neuroblastoma, which is altered by chemotherapy. And this alteration is in the form of extensive ganglionic differentiation. All these big cells are ganglion cells. And this is the stroma in the background. And there is, this is reported to be still as a neuroblastoma, which is showing extensive ganglioneuronal differentiation, which is induced by chemotherapy. I will not change the diagnosis to say ganglioneuroblastoma or even ganglioneuroma on its face value. It is biologically still a neuroblastoma.
Sure.
And we are not applying any histologic prognostic parameters to this resection.
So we did complete the remaining 2 courses of chemotherapy for this patient as per the protocol. And, the child is under follow-up for the last 1 year and is doing well. It's been 1 year since the child has completed treatment and is doing well. So, ANBL 0531 results have been published. And, I've just pulled out these graphs. These are for infants with intermediate risk neuroblastoma. And we can see that the histology does play a role in determining the outcome, the biology. So if you have a favorable biology tumor, so it is important for us to have the access to the entire biology, because this will definitely have a good prognosis if we have a favorable biology. Whereas infants with the unfavorable biology, even if they are intermediate risk, they will still, have a lot of relapses to the tune of 20 to 30%. Now, just very quickly, we have last 2 cases. Within 5 minutes, we will wind this up. This is just to highlight the last spectrum of, the low and intermediate risk. Very quickly, we'll wind this up.
So, 6-day-old male child, presented with progressive abdominal distension and respiratory distress. CBC was done, which showed hemoglobin to be 9.2 gram per deciliter, white cell count to be 15.8 per cubic millimeter, and platelet of 65,000, had massive hepatosplenomegaly on presentation.
So thank you, Dr. Vikramji, for sharing this case with us. Dr. Sandeep, the question is, you have this child who's got a massive organomegaly, And we have always read about this big hepatomegaly secondary to neuroblastoma, but how do you prove diagnosis in such a child, in such a young child with this massive organomegaly?
So again, we look at the cross-sectional imaging in this patient. If you have an adrenal tumor with hepatomegaly, then you have a diagnosis which is written on it, that is a neuroblastoma. But in a small percentage of these patients, the primary is actually occult, and you cannot make out where the primary is. The liver itself gives the morphology of the liver on CT scan itself gives you an idea, whether it is a neuroblastoma or not. It is unifocal. Then obviously you can do the biochemical parameters like the VMA and HVA. And also you can do the MIBG scan, depending on how much time you have. These children are relatively very sick. They have very severe thrombocytopenia. They have bleeding disorder, severe respiratory distress. And as I can see in the picture, a ventral hernia has already been created in this patient to tackle the respiratory distress. So it is a difficult run against the time.
So again, we will follow the similar risk stratification as we have already noticed. So Dr. Vikramjit, would you like to comment on treating such a child and the outcomes in such a patient?
Sure. So risk stratification depends on what else is involved. This is your typical pepper syndrome where you have multiple liver mets. You may not have a clear-cut primary, but you want to obviously look for evidence of marrow disease. You want to look for evidence of metastatic disease elsewhere. And provided it's confined to the liver, this would come under stage MS in spite of the child looking so sick. So these children often respond well to chemotherapy. And very often you don't have a lot of time, as Dr. Sandeep emphasized. These patients are very sick. They're either on the ventilator or about to go on the ventilator and have had a hernia created surgically to relieve some of the abdominal distress. And they will respond to chemotherapy. But the issue is often that in spite of good response initially, some of these patients will go on to recur later on in late infancy or early toddlerhood. And it's unclear why. So even though the textbooks say if they respond to 2 to 4 cycles of carboplatin etoposide and they are in remission, they should have an 80 to 90% event-free survival. But I personally had one patient who, in spite of looking like they had a great response, recurred with a classic stage 4 metastatic disease, stage M, at over a year and a half and went on to die from that. And Arpita, I know in Kolkata, has had a similar case recently. So this is something.
So like in this patient also, this child was actually MS and the NMIC was indeterminate at that point of time. But we see that if the MS has got an NMIC amplification with them, then they are actually high risk tumor. And probably that is the reason why this child relapsed and actually succumbed even after the treatment of high-risk neuroblastoma was given. So just the last case, which is again an MS case. So this is, one we manage jointly at Apollo with Dr. Amita. This is a child who at 10 days of life had an abdominal distension, and then a 1 month, 15 days CT scan revealed a hepatomegaly and an adrenal mass. So again, we are probably going towards a MS kind of a situation. There was worsening abdominal distension, and the child, when came to India, had a 64 respiratory rate, had a very gross hepatomegaly, was very sick. The baby had, had bilirubinemia, had thrombocytopenia, anemia, and even the enzymes and albumin were also low. And we can see the large mass and the huge hepatomegaly in this patient. And you can see the abdomen, and these are very, very sick children. The child was actually given chemotherapy as per the CCGS study, cyclophosphamide at 5 mg per kg for 5 days. The newer protocols, however, recommend carboplatin and etoposide as the first line of therapy. And the urinary VMA was very high in this patient, which clinched the diagnosis. We could not really do a biopsy or anything because the child was very sick. And despite treatment, the child was actually worsening. And, the the child was referred initially to the radiation oncologist in our hospital. So a multidisciplinary decision was taken to give radiation, a very low dose radiation to this baby. The baby was deteriorating in front of us, and 4.5 gray of radiation was given in 3 fractions. And this baby actually came out of that problem and is doing well 3 years post therapy. So these MS or 4S are the tricky ones. There is around a 30% mortality in these young babies. The preferred chemo is carboplatin and etoposide. People are doing away with radiation because the chemotherapy is more effective. The second line may be a hepatic artery chemoembolization. Liver transplant may need to be considered. And early resection of the primary tumor, if possible, does give a survival advantage in these patients. So I would just like to summarize by saying that neuroblastoma is a fascinating disease with varied presentation and outcomes. The staging, risk stratification, and treatment planning is best done in a multidisciplinary team fashion. The approach to managing this tumor is one of the best examples actually of how imaging, histology, biology, surgical factors, and chemotherapy amalgamate, and that sets the current paradigm for modern pediatric oncology. Thank you.
Thank you very much, Manas. I think this was a marathon session. We covered a lot of ground today. I think, especially thanks to the outside faculty, Dr. Mukta, Dr. Sandeep, who spared the time, Dr. Praveen as well, and who spared the time with us this afternoon. Any burning questions? Anything anyone wants to make a comment or ask? I think most of has been sorted out in the chat box, but any other questions we have? So it seems there are no questions. So thank you, Manas, for moderating this, and all the expert.
Thank you, Sunil, and sorry for crossing the time. I'm sorry for that.
But it's absolutely fine. I was watching, and I think everyone was hooked to the screen, so we are all good. So thank you very much, all of you, for your time. And I think I will thank all the program committee, especially Nita and Anand, for coordinating with all the moderators, and Echo and Ria for the technical support. So thank you very much, and we'll see you next Thursday. And we have changed some pattern to these sessions, and next we are incorporating some path sessions in between. So next week going to be a very interesting session which Dr. Anil Handu is going to take on flow cytometry in pediatric hematology oncology. So I think it will be a really great session to have with some case-based discussions also. So we'll see you next Thursday. Thank you very much.
Thank you.
Thank you, everybody. Thanks, Manas.
Thank you, Dr. Mukta. Thank you, Dr. Vikram, Dr.
Thanks,
Sandeep,
Manas.
Dr.
Bye.
Dr. Satish. Thank you.